Hello and welcome to my poster presentation. I'm Reece Anderson. I'm presenting on behalf of myself, Andriana Pena, Bradley Johnson, Ross Nell, Dr. Tillman Hudson, and Dr. Matt Vassar. Presenting over our project, What's in a P-Value, a fragility analysis of randomized controlled trials cited in the AUA guidelines for benign prostatic hyperplasia. Just to start out, a little bit of background. Randomized controlled trials are used in the development of clinical practice guidelines. They provide the foundation for medical research. They are the foundation of systematic reviews and meta-analyses, which are the top of the hierarchy of evidence for clinical decision making. In 2014, a group of researchers led by Walsh et al. Described the fragility index, which is a statistical calculation that uses an iterative function to determine how significant a p-value is for a study based on the amount of people in the sample that is needed to render the results non-significant. This is a metric that uses dichotomous outcome variables and thus does not lend itself to continuous outcome variables or survival data without some significant changes in the methodology. And so when we are looking at the fragility index, we are comparing studies with a different sample size. And so in order to have a one-to-one comparison, we've also developed a tool called the fragility quotient, which provides a standardized measurement for comparing studies with different sample sizes. So our objectives, we sought to evaluate the RCTs cited by the AUA, which is the American Urological Association, their clinical practice guidelines for management of BPH, through calculation of fragility index, fragility quotient for studies reporting statistically significant results for dichotomous variables. We also wanted to look at how FI and FQ were associated with clinical studies characteristics and how many patients were lost to follow-up and compare those results. So in order to start, we independently screened in a double-blind fashion the AUA guidelines citations and found all RCTs reporting significant dichotomous outcome variables. The data extracted is included in the slide below, and we used Stata 17.0 to calculate the FI through an iterative function, as well as using other various statistical softwares to calculate fragility quotient and compare the FIs against the number of patients lost to follow-up throughout the study. So here's a little diagram on how fragility index is calculated. Over here, this is the normal 2x2 contingency table that is used to determine significance between two separate treatment groups using a Fisher exact test. And in order to calculate fragility, the number of patients needed to change groups, so people who either had an event or did not have an event, number of changes in the 2x2 contingency table necessary to render a p-value non-significant. So what we did is we found that there were 24 RCTs that met inclusion criteria, and among those there were 29 distinct outcomes that we analyzed. Median fragility index was 12 with an interquartile range from 4 to 38. This fragility index of 12 suggests that on average, or on the median, 12 patients needed to switch from the event group to a non-event group for each treatment or comparison, which would nullify the statistical significance. Of note, 6 studies we found had a fragility index of less than or equal to 2, suggesting that only 1 or 2 patients needed to have not had the outcome of interest in order to make a non-significant result. Furthermore, 10 of these 24 RCTs, the number of patients lost to follow-up was actually greater than the FI, suggesting that there's room for speculation on how significant a study's results are. Here's a histogram showing the distribution of fragility indices for the studies included in our sample. There's a pretty wide range, all the way up as high as 123. So in conclusion, the AUA clinical practice guidelines for BPH cite RCTs with more robust findings compared to previous studies assessing fragility in the field of urology. There is room for improvement, and one area of improvement would be to have authors and journals cite the fragility index as part of a more complete picture of reporting their results. Here are our references and any contact information. Feel free to reach out if you have any questions. Thank you so much.